Hello and welcome to a new episode of DHI4L, which is Digital Health Innovations for Long Life. Today we have with us Mr. Rajesh Reddy. He was also my student sometime before, almost like a few years before, I guess. And to know more about him, we will ask him directly. Welcome to the show, Mr. Rajesh. So, what are you doing now?
Thank you, Dr. Suresh. Uh, I am currently working with the California Health Department, which is called as DHCS. It's a Department of Healthcare Services. I work as a data ops specialist, and we do provide medical services for lower income families.
I think we had a discussion before. So, this is similar to Arogyashri or Ayushman Bharat health scheme in India.
Yes, it is. So, in America, they have a system to provide medical services. They call it Medicaid and Medicare. So they segregate services on three stages: medical, dental, and behavioral health services. So Arogyashri is like one umbrella in India, and they provide services for people who are not able to pay for their medical services. And there are eligibilities, like in India they have different colored cards, like the white card or the pink card, and financial eligibility criteria. Similarly, based on the amount of money they earn in US and the number of people present in the family, they have eligibility criteria. So someone has to enroll for it.
Well, we'll hold on the discussion on the health systems, but we'll go back to Mr. Rajesh's beginning. So, when and where were you born?
I was born in a very small town called Pulivendula, and it's in Kadapa district.
Can I ask the question when, or it's a bit too difficult?
I was okay. I'm born in 1989 and December, and my parents still live there. And then I grew up with my grandparents in Anantapur, and then after finishing my school, I moved to Chennai for my higher education.
And where did you study in Chennai?
I studied in Sathyabama University. I did my undergraduate in biomedical engineering and postgraduate in medical instrumentation. After that, I did a course with Indian Institute of Public Health, where there is a health informatics program which was headed by Dr. Suresh, which is you. So that's what I studied.
Okay, so I believe you also worked in the middle before you joined us. So, I think if we can trace your career, probably step by step, that would be really helpful for the audience.
Cool. So my first job is an assistant professor. Just after finishing college, I worked for a very small engineering college in a small town near Kanyakumari. It's called Uday Engineering College. I used to teach third year and final year students and master degree students medical optics, image processing, hospital management, and stuff. Once it is done, I moved to Hyderabad. I used to train podiatrists all over India in wound care management. I used to work for a company called Kerecis India, when they are trying to implement their wound care product into India. And after Kerecis, I got an opportunity to move to US. I used to work with an organization called Akshay Patra Foundation, where I did lots of project management for their religious nonprofits, and I tried connecting them with I'm like a liaison between governments and nonprofits. During that process, one of the patents that I worked for, one of my friends, he's a nurse in New York. We designed a multi-needle syringe, and that patent got approved. That's when, like, okay, fine, I think my path has been completely different. I need to just come back and start doing something else. So I started my company again, and then because of the research costs, I moved back to India and started company, and that's how I met Dr. Suresh, and the innovation part started from there.
So, Can you describe any projects that you did during bachelor's, master's, uh, both places, Sathyabama and at IIPH when you are with us?
Mm-hmm. Sure. So one of my master degree projects is to innovate a systematic reader where a blind person can take a picture and the picture converts the text to voice. So it detects the text in the picture and then it converts into voice. This is like in 2011.
I think a lot of these things today people take it for granted, or
Yes.
maybe it's fairly very obvious. Where
Yes.
you just take a photo and then you have generate AI reading everything from
Mm-hmm.
that. But I think 10 years or maybe almost 12, 13 years before, these are all very novel actually.
Right. So 14 years before, so what we did is like, we don't have enough processing powers also then. So the processing powers today versus the processing powers then was completely different. I mean, I used to upload like 5 or 6 images, run the program. I used to work, I did develop some Java program code for that, where we used MATLAB for multiple image processing techniques, and then color correct it, pixelate and all those. Then there is a reader, and then the voice is converted into, so then the text is converted into voice. So it's a semi automatic process, but now everything is made as an app because of the processing power and technology improvements.
Yes, and while you are with us at IIPH, I think you worked with us on a lot of projects actually, and in fact, we did a lot of traveling also,
Yes.
almost throughout the country. COVID was also there, and I do remember you even like living at IIPH because movement was extremely restricted, and running our 3D printers, and then I would even use the word tending to the 3D printers because they needed a lot of care and tending, I guess.
Yes.
So, can you describe some of the work that you did with us at IIPH?
Yeah, for sure. So the work at IIPH I've taken care is more of an transferring idea to implementing a project. So I did I did materialize lots of ideas. So one of the project that I can talk about is developing a software, developing an icon based software where the health workers can completely take out the paper based digital entry, take out the paper based entry, and take the app to the field. So there is lots of innovation around it. When the healthcare worker is going to the doorstep, so we tried not just for data collection but to provide return back services also. So the innovation around it is, what do they carry, how do they carry, and how do the processes work. So one of the coolest things that we have done and patented is a box which has not been redesigned from ages. It's the blue box that current day ASHA workers carry around, which doesn't have any temperature regulator systems. No one knows like what is
The vaccine carrier box.
the vaccine carrier boxes. So no one knows like what's the temperature being maintained and all those. But to prototype that, we started 3D printing. So we fortunately had a designer who was patient enough to work with us, and we started like, we wanted to try building prototypes, but prototype being like super expensive those days, and there is lots of like our requirements not being translated. So what we did is like we actually started learning like how do we do it. So there was the learning curve. There was like there is a failure. Like I still remember that those days where like the print that I used to start like which can go like 80 hours, 90 hours. And then I used to like, we had like, there is one more person who used to work with us. Like there is this guy sitting next to the computer, like next to the 3D printer looking at it, like, is this going on good? And then I used to walk in like every 2 hours and see if the filaments are good. And one power cut or like 1 second gap of it, like the whole 80-hour thing can be lost absolutely, and that's a useless material.
And it involves a lot of praying also.
Yes. But as part of the learning curve, so we started utilizing those broken parts also. So we started like we learned techniques, how to merge them, how to build, like reuse those things. So those are like the cool projects, but the technology has been much more improved. The logistics has been much more improved after COVID. I can see that filaments were not being sufficiently available during the COVID phase, because I have power, I have machine, I have person, I have design, but I don't have filament. So there are challenges. There are implementations that we have done. So we have trained people, like we have like pictures of 132 cell phones, and then 132 people being trained on those cell phones. The app that has only icons to screen people. So there is lots of innovation. There is lots of projects that we did, and we flew drones. We built drones completely from scratch.
Yeah, fairly large, heavy payload, slightly longer range drones. That I think it was built to carry about 16 kgs or something, and still relatively larger drones are a bit of a rarity in India. Not as much with our neighbor, but in India it's still a bit of a rarity. So
Yeah, so we did build a proper shape to a drone, not just like a bare skeleton, which is like a cool looking thing. Yeah.
uh, slightly bit off track from the academic work. Uh, you would have lived through this time period where there was once a time where you had these old phones and now you have these smartphones. So what was your first phone?
My first phone was like Nokia 2280, the blue one where Reliance used to sell. Like previously the phones were connected to carrier only, right? So it used to be like a brick. I once threw that phone from maybe like 2 floors or something. The battery came out, nothing broke, just went down. I like super scared because I broke a phone, but put in the battery back and it started working. I used that phone after 6 months also, so it's a cool thing, yeah.
And you're a biker and a long trip driver. So are you still doing those things or?
Yes, I did. So after moving to US, I did not do so much as I used to do in India, but I did. I currently, like, own this motorcycle called Suzuki V-Strom 650, exclusively made for adventure enthusiasts who wanted to cross countries. I did some, like, I just crossed a state there, but from India I crossed countries, so I can't compare those two things.
I think in India you had what bikes did you have?
So
KTM.
yeah, like I had a collection.
Yeah.
So my first, after starting traveling, like after starting long distance travel, my first one was Classics 350 and Interceptor 650 and KTM 390. So the funniest thing that happened was, like, I purchased a motorcycle from Banjara Hills, Hyderabad, and I took that motorcycle for first service at Varanasi, Uttar Pradesh. So that's the scale I traveled.
Is there any specific cuisine or food that you actually like?
Street food any day, Indian street food.
I'm sure you would miss that being in America.
Yeah, 100%. Just trying to get those tastes from Mexican restaurants, but
I guess it's not the same.
yeah, definitely not.
Well, that's great to know about your adventurous side. Getting back to, I wouldn't call academics, but rather our perspective for today, which is digital health. As you are aware, we have started India's first school of digital health at Mallaradi Vishwavidyapith. And you also enrolled for part-time PhD with us to continue your exploration on the digital health side. In your opinion, if you keep everything out, what is present, or maybe only focus on future in a slightly imaginative way, how do you think digital health will help the patient, provider, and also the payer as the third part?
Sure. To answer your question in a very wide format, trying to understand or trying to realize like what is the number of citizens like living in the country. If you so they have Aadhaar being introduced, so every citizen is having an Aadhaar card, which is like that gives the number of people present in the country any day, at least like maybe 95 to 96% accurate. Now the death registration, the birth registration happens at least fairly like 60 to 70% in this country as of today. They're trying as much as they can, enforcing like the birth and death registers has to be done. So if you see the back end of this data, any day you can find out what is happening in this country, how many deaths were there, how many births were there, and how do they track them, like where were these, and like the Aadhaar has the address, like biometrics and stuff, but if I just see the address, I can get the population of a state or population of a district at least 80% fairly, 80 to 85% fairly, because people could move but they don't update. But on an average, on a bigger scale, they can be tracked, they can be utilized for better governance. In the same way, with the digital health being consider like you went to a clinic last year, something happened, and you have like folders and folders and folders that's been tracked, like kept in the closets, never being looked at. And the doctor, if you walk into the clinic and you take all those bunch of papers, like, do they have time to look at it? No. I mean, like, they're not even interested to look at it. They'll ask you, and whatever you say or whatever your knowledge is, that's something that is being translated to your doctor, not what actuals are. So digital health is like, imagine like you taking pictures of your health. Like you have pictures, like the last memory, and you were 5 years old, you had a picture, and whatever happened, you have a story about it. Now, if the doctor looks at you broke your bone at like in class 7, because I did that. So and now the doctor can clearly tell, like, this is what happened, and these are the treatment procedures used, and like I'm allergic to so and so medication, and this is the time frame that took to heal, etc., etc. So by standardizing digital health, you can get better health served any day.
How is this helpful to the payers and the providers also? I mean, you spoke from the perspective of the patient.
Yes.
It would be really great if my entire medical history is available to the doctor.
Mm-hmm.
So how is it actually helpful to the the service provider here, which could be a hospital,
mm-hmm.
or maybe an outpatient clinic, and if the person is covered with insurance,
mm-hmm.
to the payer also?
I'll tell you both perspectives of private insurance and government insurance also. So at the end of the day, payer always wanted to understand what is the amount of money they're being spent. Let's think city of Hyderabad or like government of India wanted to spend like X number of crores on diabetes. How do you know that? So the policy people have very imaginative numbers that are being run. So based on those numbers, it could be either under granted or over granted. Over granted, I don't think it could ever happen. So it is always under granted. But being under granted, like, are those services, like whatever the program is designed for, is the reach being happening? So if you want your health systems to be empowered, it has to be properly documented. The documents are the numbers. Like India has like 5 crore people who are having this type of disease. And our government wanted to make sure that this disease is being treated in a certain way. So now when there is a grant that is being given out, there's insurance. I'll tell an American story for these insurances later, but uh, the insurance companies, if they are very well known about how how many people can be affected with so and so disease. Now, insurance companies like private insurance companies could be sometimes really smart. That's why they kind of exclude certain diseases from being paid to.
But I guess governments cannot do that because it will become a social issue.
Yes, governments can do that. Yes.
I also remember a couple of instances where government actually said, okay, we'll provide treatment to thalassemia, and based on some number they announced some money, and then when obviously government says I'll do it for free, uh, the actual response was 10 times, and this money was utilized in the first 2 months itself, which means you made a promise to the people and then you are not able to keep it for the next 10
Mhm.
months. So, as you rightly said, I think having an idea on the actual numbers uh, helps a lot in decision making. And maybe another example, I think Andhra was the first state to privatize diagnostics. So, most of the PHCs were turned into actual collection centers, and samples were actually collected and sent to a private organization, or an organization came and collected them and then did the analysis and sent the reports directly to mobile phones, mobile phone numbers. So once the government started this, uh, based on certain assumptions or based on existing, kind of patient flow to the clinics, uh, the reality was because it was free, the actual number went up by 5 times to 10 times. So again, government committed to certain amount to a private organization, and then suddenly there is a 5x.
Mhm.
You can't restrict people walking into a government free facility. So
Right.
again, it becomes very challenging.
Mhm.
So this is where, as you said, if you don't have the right numbers, either the quality of the service will suffer, or basically the quantity itself will have to be reduced because money has run out.
Right.
Um, but isn't collecting all this data challenging? How does your experience in America works? How does you think, or how do you think it works in India?
Sure. To give you a better example, like how this HO Rapid Lab has developed a icon-based software, eliminating the need of paper-based systems. So, if the disease screening is being done based on paper-based, the translation factor from paper-based to a digital computer, and then it is sent to some office of health or something like that, there could be like close to 30 to 40% of error. I think that's what we have seen pictures like 6-7 years ago when we visited some PHCs and all those. So the numbers are always the game changers. With the paper-based systems, I don't think that was being properly tracked, but with the digital things, yes, that could be was being properly tracked, but with the digital things, yes, that could be absolutely tracked. So my experience with the American data collection thing is, my experience is like maybe from past 4 years or 5 years only, which is the digital era. There is very I don't think I have ever seen a paper-based system in the last 5 years, even if it is a drug abuse drive or behavioral health drive or a dental health drive or like a cancer screening drive, people collecting data. Like, there was never a paper. There is always an app or a website. Then the healthcare worker always carries an iPad or something. They just enter everything. and this data is being directly translated to the numbers. So the loss of those numbers is very, very minimal. That's where accurate decisions can be done. But on the same line, even if today, though India is trying to build the digital health IDs, etc., for the primary health centers or anyone who wanted to take the government services, even if other being there is other authentication, etc., that's being tracked, but how the system being connected and how it is being tracked and how it is being used, I have no clue. So there is still existence of paper-based systems. So I've seen a picture of this. Someone is writing it on like a notebook, and then they're entering all this data entry. So even the closest example is like someone wrote their name and the name has been like RAJESH instead of that RA, like the letters got like reversed or something like that. So there is chances of always the translational errors from paper-based to digital ones. I think that's something that I have seen in India as of today also. Going forward, I suggest, or maybe I hope for digital systems where, because like internet is everywhere, everyone is carrying a phone. I think that's the innovation factor that HR Rapid Lab, Dr. Suresh's idea to completely eliminate, don't take paper, just carry your smartphone, put in the app, it's just one app, train healthcare workers on those icons and tap, 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 and you're good to go.
You mentioned about programs in America, where, as you said, you have actually never seen a paper-based service at all in the last 5 years.
Yes.
All the programs are completely digital. Just to kind of put some numbers into perspective, because you are now focusing on the numbers part. How many people or patients do one provider see in America per day on a per day basis?
So to answer that question exactly like how you asked, like number of, there will be like close to 20-minute appointments, 20-minute to 30-minute appointments per member. So 6 to 7 hours per day is like 6 in, how much is that, like
20 minutes per 3 appointments per hour, so 6 is 18.
18, yeah, 18, but I think could be 12 to 15.
Okay. And
but I have a continuation for that.
Yes.
But there are multiple appointments that are being done. They don't see the provider directly. There is an RN, there is an MA. So MA,
RN means?
okay, there is a registered nurse and there is a medical assistant. So the medical assistant is someone who guides the member who walks in to see the consultant, like the provider. Sometimes it could be just a nurse visit. It could be a flu shot. It could be a prescription that just needs to be generated again. So that's where the appointment kind of, the provider could be really free, but it's like the basis. So if I'm going to the hospital, I'll meet the reception and the MO walks in and the medical assistant does all the preliminary things, and then the RN the registered nurse will take a look at like what is that I am there for, and then the RN tells the provider, okay, this is the summary, and then that's when I see the provider. So unless it is really needed, the provider is not seeing me.
So this 20 minutes that you mentioned, is the summary of all these 3 visits, or it's like each visit again still adds up?
Each visit adds up.
So maybe 5-10 minutes with the medical assistant at the first level, again another 5-10 minutes with the registered nurse, and then you're talking about 20 minutes with the doctor or the provider.
So wait times could be fluctuating.
We're not talking about the wait times per se, but the actual
It will be like 5 minutes.
Okay.
Just 5 minutes for both RN and registered nurse and MA.
So per patient takes about 30 minutes.
Close to, yeah.
Okay.
Excluding wait times. Wait times could be more.
And does the people, I mean the three people you mentioned, do they spend even more time documenting the data, or this 30 minutes actually includes the data documentation?
So it's a parallel thing that happens, because I think to explain this, I should tell what happens in the background. If I call my hospital and say that I need to make an appointment to see my general physician, like I feel like, let's think I need to go do my annual body checkup, or like my blood test needs to be done, or maybe I have something that is bothering me, I wanted to see a provider. Now I call the healthcare, the hospital number, and they said like, okay, fine, this is my MRN, like the medical record number, and this is my name, this is my date of birth. Once it is verified, the receptionist kind of gives an appointment, and the slots, they'll give you like, these are the slots available, and then once it is done, I have to be there the day it is being selected. There are some private health hospitals that does lots of online booking as of today, but not every community health center does that. So I need to call my community health center, because if I am running on, let's think, Aragyasri, because I am from a low income population, I wanted to get treated, or I wanted being checked, I'll call the community health center, and the community health center gives me an appointment. I walk in and does the check-in process. The check-in process kind of takes basic information and makes sure that the demographics of mine and the income status and number of people living in my household, everything is being updated, and then I go to the reception waiting area. And once I know that once the receptionist clicks on check-in, the medical assistant gets notified that there is this guy waiting in the waiting hall, and I'll be guided there. Now, the medical assistant tells RN, if necessarily, the RN will take a look at my medical history. Why is this guy here? Now, there is the decision factor. Like, so there is this thing like appointment provider and servicing provider. So the appointment provider could be completely different from a servicing provider. Servicing provider is nothing but the doctor whom you are seeing. The appointment provider could be someone who is a full-time employee of that hospital. Because of the financial issues that has, where there could not be full-time providers at the hospital, so there will be only one appointment provider and could be multiple service providers. So I will be, if I don't have a choice of provider, I will be sent to the next available provider based on the need of my case. So that's what happens. And to do these things, now the RN will type some notes, like whatever happened, like why is he here and all those. These notes as a summary will be seen by the provider, the actual provider whom I'm talking with. Now the provider will have a computer and the keyboard. This is what I have experienced and I've seen in my previous health clinics also.
Essentially, there's a fourth person in this group who's the appointment creator.
It's a reception.
Okay.
Because there are so many people involved, because there is a call center who takes the calls. Okay. There is a reception who checks in. So it's a big thing. And then there is a eligibility check also that happens.
So by the time you end up finally visiting your RN who can take a decision, clinical decision also, or a doctor, there are at least 4 or 5 people before that. And this actually works like throughout the country, or is there any region-specific services also?
So the rural health centers, it's called RHCs and FQHCs, Federally Qualified Health Centers, and community health centers, the format is same. depending on the size of populations, depending on the number of appointments, the wait times and the processes could change a bit, very little, because the rural health in America is a bit scary because of the vast distance between the clinic and the cities, and they have problems too.
Okay. You mentioned problems, which obviously distance is a problem.
Yes.
But the way that you put it, at least for OP, it all looks like it is working. So, is there any problems with AP? Outpatient clinic.
Outpatient clinic, yes.
There are 5 steps, and I mean, you put it in a very positive way. So, what exactly are the challenges?
So the challenges could be wait times. Definitely, like wait times is the scariest thing, because even if you see the recent the Canadian death that happened, someone is waiting, them being treated, and someone passed away. So the wait times could be really scary. I mean, we still used to get calls when I used to work for an FQHC asking for, like, can you please do this, can you please do that. But sometimes members panic and can't make it as an emergency when it is not required also, but that's more of a mindset thing. So we don't know who to give appointment on an emergency basis. So that's why it is very clear that OP and emergency are like completely different. So the outpatient non-emergency care has lots of wait times. I think if I call today, the average wait time was like around 7 to 11 days.
But that's broadly what you call a factor of how many people are providing a service. I mean, the broad answer to that is if you increase the number of providers, wait times go down. If you look at it from the perspective of data or any ecosystem challenges, I'm not sure if the number of languages that are spoken in America are as diverse as what is happening in India. So, is there any other data related challenges or ecosystem related challenges or skill related challenges?
Yes, 100% there are challenges, like digital challenges or the modern problems, I call it. As I told, the insurance company, whatever is providing them, or to be kept in this way. So if I am eligible Medicaid member, which is like an Aragashree member here, I have to be enrolled through a insurance company. So let's think I am being okay this year, and then insurance has to be enrolled every year. It is not an automatic thing. So every year there is an eligibility check, like you need to select few check boxes to see if you are eligible or not. Once you are eligible, it will be automatically given based on your zip code. You will be assigned a company. Now this company will where did we cross this line? Like I lost the track.
Eligibility criteria where people have to enroll. The challenges in digital.
Challenges in this. Okay, right. So if I was in, let's think I was in Hyderabad, and now I moved to another city in Hyderabad. So there could be a challenging factor here, which is unseen, is the EHR changes. The health center in Hyderabad, because it's a bigger health center, or bigger, has lots of grant or lots of money, might use a better EHR than the smaller ones. Like, I don't think I can use names of those, but differences in EHRs. Now those two EHRs don't talk to each other. So every health center will have access to those EHRs just to see patient demographics and eligibility criteria only. Now, if I go to, let's think, a smaller second tier town and I wanted to get something treated, there will be one registered nurse who knows something about EHR, who is being trained about EHR. This RN kind of goes in and see like the name, date of birth, and MRN, and could be our SSN. Give that and see what are the eligible factors, and it has to be a manual step where someone has to put in their MRN the medical record number, and see what has happened in the other side of the world. And providers, because there is a limited time, they can't do it. If I told you the RN work, whatever the summary RN is typing, this is what they do before the eligibility checks. I mean, like when I call for an appointment, my appointment won't be confirmed right then and there. I will get a call back later, because there is a eligibility check specialist who takes your details and provide eligibility check, whether are you eligible. Big thing is, if you are not eligible, if I provide treatment, I don't get paid. So as a health center, I should make sure that you are eligible, and the eligible population being covered by certain insurance. And if the insurance is taking care of this, so insurance has the database where every MRN or every name, the first name, last name, date of birth, and the address and phone number will be provided to the hospitals on a monthly scheme. Like every new enrollment will be happening. So it's a bigger ecosystem than expected.
Broadly, two questions here. One, the whole system seems to be extremely data heavy compared to, or rather, if I see it from an Indian perspective.
Mm-hmm.
How much tech savvy or how much skilled are people in these computers, and how much data does each person generate, and does everybody has this kind of longitudinal records, or everybody is enrolled into the insurance scheme? What happens if people are not enrolled? I mean, they won't be part of any system at all, right? Or that's a complete rarity in America.
Okay, so what happens when someone is not enrolled? Their care get delayed. If someone is not enrolled, they have to go through the enrollment process. So your first name, last name, and your date of birth, and your SSN, like Aadhaar in India, or PAN in India, PAN card number in India. So that will be given to eligibility specialists, and they will make sure, they will guide. I mean, like, hospital can't take care of enrollment because they have their own duties to do. So they will guide you to the nearest, the social security officers or the health enrollment officers, where the eligible member or the care required member has to walk in and do a manual thing.
So is this the same place where they have to update annually, or that's done?
You can do it online. You can do it online. I mean, so
this is only for first time enrollment.
If you never had, I mean, like, so there is a population who has experiencing drug abuse or behavioral health abuse. They have no phones, like being homeless. They don't have anything. All they know is like their name and their phone number or like their previous addresses. So if I get an outpatient who requires a behavioral health treatment, I mean, like, I'm completely clueless. The homeless person who we wanted to serve, like, we have good intention, but we don't know, like, what is his eligibility. I mean, like, how is he being tracked and all those things. So to put all these things, again, it's a bigger thing. Like, the homeless shelters are there, where we try to connect them, and the services are being tracked separately. So we do provide, and then there is some, I'm not sure, like, what is it called? Enrollment specialist, eligibility specialist. Someone from the operations team kind of sends them to the right locations, and then the care can be provided.
Let's look at the positive side where things work. Isn't this too much data? Does the provider, let's assume that there's a 40-year-old or a 60-year-old person walking in. If he is even visiting a doctor once in a year or even once in 5 years, you would have generated substantial amount of data. How much of this is actually being read by the service provider at the point of care? How much of this actually makes sense? And who's bearing the cost for storing all this data? Is it available to any patient anytime or any service provider anytime? So can you just run through this? so-called health record of a person?
Sure. I'll run through this connecting the last question also. So how much tech savvy are the hospital staff also? So hospitals do spend lots of time, money, effort training these people because garbage in, garbage out. Anything, anything wrong just by one code could completely change the timeline of a patient walking in. Now, so that's where the tech savvy thing walks in. Like everyone will have like at least basic understanding on computer. Also, also they have understanding on the EHR system they are being trained on. So my previous health system used eClinical Works. So if I get a new healthcare staff, so we train them on this eClinical. I mean, they don't need to know the entire EHR ecosystem. Now the receptionist there just knows about appointment times, the check-in procedures. The eligibility specialist knows. So they're like completely siloed understanding, but people like me who should look at the complete ecosystem has to go through like how do appointment works, how do reporting works, so what is the measures thing that I can do, like
is there a certification process, or is it like they have to take a course sort of?
Every EHR is different. So eClinical Works kind of trains people like if I'm having a health center, if I wanted to train like 5 people, so for the 5 people we will be billed like X number of hours, and they'll be having a private class kind of stuff for 2 days or something.
The so-called electronic health record provider actually trains the users also.
The user support technical team, yes. And then if you have a new question, I can. Okay. Now regarding the storage and the bulk amount of data that goes behind, even if you are visiting once, there are different segments of data that we collect, or the segments of data that being used. The segments of data meaning there could be a demographic based data, there could be a clinical based data, there could be a what is it called, like the future, what happened for this guy, the past, or the disease tracking data. So demographic data is majorly used for policy or understanding or taking decisions for the boards, like the board of the hospital or the county staff, the district staff or the state level staff. So it's more of that, but nothing that has nothing to do with the provider. So where you are from, he doesn't mind, he or she doesn't mind. So if whatever diagnosis that is being done, that's where the RN is more focused on, like what was this diagnosis and what happens, and the summaries is majorly read by the providers. So everything is siloed, everything is separate. I mean, the load of this data, even if you are attending once or even if you are not attending once, it has to be tracked. I mean, if my health center being asked about, so there are like this thing called like health care measures, like how do you measure performance, like we have like 1,000 people living in the zip code who are eligible populations. We get the health center, we get a email from the insurance company with the list of people who are eligible or assigned to that health center. There is an outreach team, they call them and say like, hey, how are you doing, like this is what you're being so and so thing. Like there is the outreach part from hospital also, and we do track that. And the payment for the data is like health center owns the data. Health center has data, majorly it is currently it's cloud, like ECW has eClinical Works or any other EHR. Every data set is cloud, everything is under HIPAA compliance, not anyone can see, everything is encrypted. Only very few people can see all the data in the health center.
Who can see?
Uh, Provider can see. A data analytics guy like me can see. Operations can see some part of it. So this is where like there is always a level and filter. Receptionist don't need to see what is happened with their diagnosis. So there is always like, okay, you can see only this much. But like 100%, quality teams can see everything, data guys can see everything, providers can see everything, CEOs, no, like they don't need, I mean, like most of the CEOs don't even spend time understanding what's going on because that's not their problem. So,
Okay, so there's broadly lots and lots of data that seems to be associated. Uh, Maybe one more question, a little bit more in detail. So everybody has to enter data, otherwise
yes,
it's not going to be captured. So how is data being captured? I mean, obviously, if you're looking at radiology, you're taking an X-ray or an MRI, but otherwise, a lot of them are consultation. So is it simply like things that have to be typed or voice recording? As you mentioned in the beginning of your project, take an image and then it converts to some information.
Right.
So, is there a multimodal data capture or everything is like clicking keyboards?
Keyboards, like manual entry only. Like the receptionist or the call center employee will enter data. To give you the scary part here, because when I joined this health center, so there is something called UDS. UDS is like a reporting system for federal government because the health center was an FQHC, federally qualified health center. When I'm submitting this annual utilization report for the federal government, we realized the number of duplicates or the number of mismatch information, those things is like over 30% of errors. Names don't match, and there could be an appointment, but the appointment is done, but there could be a missing doctor notes, which has been like 6 months ago. Does the provider remember that? No one knows. So there are like the scary parts, but on the scale that I learned, I did sit with the receptionist and the call center people. I trained them like, okay, make sure you are entering correct. There is always a check where, can you please check again? Okay, so that kind of helps us, guys like me who does lots of reporting to federal governments or like trying to understand impact analysis or do some predictive analysis like, okay, this month we can expect 500 appointments. Are we ready to do that? So there could be a flu season, there could be a cancer drive, like breast cancer screening, 2 months. So the health plans incentivize hospitals. Sometimes like if you do 25 healthcare like breast cancer screenings, we will incentivize with maybe like $10,000 or something like that, just making sure that women in that community being checked. So there are multiple things like that. So to do all these things, data is the key.
So broadly, I mean, the way I see it, very distant and based on the conversation that we are having, I think there are two major bottlenecks. One is at the first point of data entry, because that's where most of the errors do happen, and we keep saying it's human to err, but it's also human to create a lot of chain reaction problems if an error actually happens at that point. AI comes in, but in my assumption, I think the error rate with present level of AI is going to be higher, or maybe, I don't know. I don't think it will fully address, because instead of typing, if you're dependent on voice, again, there are a lot of variations. The second area that I'm seeing as a bottleneck is the interoperability part, as you mentioned. there are different EHRs across different providers,
Right.
different versions of them,
Mhm.
and that's a technical issue, whereas the first part is actually a human issue. Any
Right.
other serious challenges other than the finance part and the fact that there's always fewer providers?
For I mean, like, yeah, I don't have anything on top of my mind right now.
That's great. I mean, probably that's why the health systems there work. And if we probably ask about India, I'm sure we'll have lots and lots of challenges.
Yeah.
It's actually great discussing with you on how the American health system works, especially at a very granular level, step by step level. We also hope that similar systems, maybe completely digital systems,
Mhm.
one day would be a reality. But as you know, there are a lot of ecosystem issues in India, not just interoperability issues.
Right.
Uh, Healthcare service is provided in local language, taught in probably English or
Mhm.
the global languages, and softwares are still in English. They are not yet that great in regional languages. And if everybody has to again type in regional language,
Yeah.
I think that's again going to be a serious complication
Right.
because I don't know if anybody is typing in regional languages these days.
Mhm.
So I think even if you look at these two challenges, the way I see it is 100x a challenge in India,
Yes.
and I think we'll hold on to that. I don't think we are going to find a solution to these challenges in our current conversation.
Uh-huh.
Uh, but going back to the fact that we are at Mallarity School of Digital Health and at the Mallarity Vishwavidyapith, these are some of the skills that we need to teach the students also. Electronic health records, how
Yes.
do you use them? How do you understand and then identify the challenges? Probably also maybe contribute to the solution.
Mhm.
What are all the skills you think the students who are pursuing digital health or any of the other courses that we are offering should actually learn?
Okay. So traditionally, most of the medical students or digital health students or anyone, so it's more into siloed learning. So they are great at practicing clinical medicine, but could not be having understanding on how systems work. So if they know or understand the impact what data can make, then if they can be taught about, like, okay, fine, using these things or these skills, like if you understand how do you see demographics, how do you see qualitative and quantitative methods, if they improve their or like if they add on their knowledge with some data or on an eagle eye view, they don't need to kind of start using Power BI or build some visualizations. They should be able to just try seeing perspective basis. Then I think they understand the need for it, and then there could be definitely a change in the way they look at the current public health or the preventive care, how it's working.
We also run a program, bachelor's and master's in medical robotics, which again is a lot of skill dependent on building products. So anything to kind of upskill students with regard to devices, medical robotics, what are the areas that they should actually focus on?
So fortunately, we are in the era where if someone really wanted to build something, like there are AI-based systems like which teaches like step by step, but all I see is how they are being mentored, how they are being directed, like instead of just making them sit in a classroom and open the book, do with your tests and get out of the college, making them think about, give them a challenge, let them go around.
So this is like advice for the faculty and the school, not necessarily to the students.
I mean, students can just ask your faculty, like, what is the problem that I can solve?
Okay.
So just walk into your lab or just talk to your staff saying that, okay, what is the problem that I can solve? What is that I can build? I mean, I still remember. So there was this experiment in a digital digital health lab, which I used to do during medical instrumentation for my master's degree. There is like 12 experiments in a book, and the 12th one is the toughest one. I walked in, like, even my staff told, like, no, let's not do that experiment at all. I have done mine, but I just took all the extra time to build the small resistor thing. I mean, like, we just worked on it. I might have burned some resistors and capacitors, but that's totally fine. You learn through those things. And I worked on it. I mean, I did finish that whole experiment, and I did that experiment for my finals also. So that it could be that, you know, if you are enthusiastic about doing things, you upskill. I mean,
I think probably that's how we ended up building the drones also. And,
yes.
Not just burnt a resistor, but crashed a drone.
Crashed
it. Yeah, I think so-called learning by doing is perhaps the best way. And as you said, I think there should also be some broad guidance on which direction to take, and maybe provide them with some challenges that maybe not everyone, but some of them who actually want to take up the challenges and learn will actually pick them up and go forward. Any organizations that you know in India or internationally in areas of digital health, electronic health records, where we can have them as a reference and say, okay, let's quickly follow them and learn a little bit faster than doing all those things theoretically through textbooks, which I'm not sure even actually exist for India.
So I don't have like organizations, but I can just give an overview on. See, if you go to YouTube, there is like the guy in the cube who does lots of. It's a YouTube channel, the guy in the cube who does lots of analysis with Power BI, and there is one more Indian guy who lives in New Zealand. He does, I think he's Chandu, CHANDOO or something. So he does lots of Excel based and Power BI. So this is the thing. Just now remember this. So for your last question, everyone says, I know how to use Excel. But what does that mean? Like, just put in and add, subtract. That's not how Excel is designed. So like, if you start learning Excel, like, try to build, do you know pivot tables? Do you know what happens behind it? Can you create visualizations? So that's the upskill I'm talking about. Your textbook might say Excel, your course might tell just about, okay, learn Excel. Okay, I know how to open it, I know how to save it. Okay, I know just like, tables and charts. No, try to put in like, how do we transform data? There is something called power transform. How do you transform data? How do you extract date, like day of the week or something like that. So there is so much behind scenes that someone can do it. Like, I have seen some positions where like Excel analyst. How many of us know about, like, we all know about Excel. Like, do we know how to build visualizations? But like, can we transform some data in Excel? No.
A lot of these platforms are incredibly powerful, actually.
Yes.
But we just seem to skim the surface and broadly assume that if we are able to open the software itself and then maybe click a few buttons and we have become an expert. But there's actually a lot.
Right.
In fact, I wouldn't probably call it that way, but if you had good data, you don't actually need all the so-called very expensive or extremely complicated softwares. Really good softwares, good data, and always a good person who can experiment and give it a try in different ways can actually come out with fairly good outputs. And maybe one more way they can actually upskill is perhaps like by watching this video also, and maybe if anybody asks next time, we should also add our YouTube channel to the
yes,
the
for sure.
YouTube that people should actually watch.
Right.
Well, it's been great talking to you and learning all those things. And we will try to implement all the things that we just now spoke about as part of our program. You are also doing PhD with us.
Yes, I
am. So I guess like you could also join us and then start implementing and start helping us. And
yes.
working on all these things. Fantastic talking to you, and hope we stay in touch.
For sure, Dr. Suresh.
At least for the next 4 years.
Yes. I'm very happy to collaborate with Dr. Suresh and team. Always very innovative and like very future thinking, and we are hoping to build more crazier projects and try to bring some bigger changes in countrywide things like whatever we did. We have screened over 1 million population.
Yes.
Yes. So hoping for.
Initially, when we said million, it was like, is it even possible? But now
Yeah.
I think after a million, 10, 100 million also looks possible.
Yeah.
Provided there are resources, and I think there are still a lot more challenges to address.
Right.
We will go forward. I think.
Sure. I trust that.
Yeah. Thank you.
Thank you so much, Dr. Suresh.